Chapter 6 Disorders of Emotion. Terms such as depression, anxiety, etc. are used for normal emotional reactions as well as for disorders requiring treatment. This failure to differentiate has serious implications, since not only does it cause linguistic confusion, but it fails to distinguish the normal from the abnormal. Let's discuss some such terms. A feeling can be defined as a positive or negative reaction to some experience or event, and is the subjective or experiential aspect of emotion. An emotion is a stirred-up state caused by physiological changes occurring as a response to some event, and which tends to maintain or abolish the causative event. Mood is a pervasive and sustained emotion that colors the person's perception of the world. And finally, affect, meaning short-lived emotion, is defined as the patient's present emotional responsiveness. Classification. Normal emotional reactions. There is little to assess the clinician, but a period of 6 to 12 months is usually mentioned in relation to the duration of normal grief reactions. The period of dysfunction requiring leave from work in the immediate aftermath is less certain and probably ranges from few days to few weeks. Some emotional reactions are normal responses to regular events, as mentioned just now, that is grief reactions that follow the death of a loved one, or to primary morbid psychological experiences, which is understandable distress that many patients exhibit when they experience hallucinations or other psychotic symptoms. Abnormal emotional reactions. These are states that are understandable in the context of stressful events, but are associated with more prolonged impairment of functioning. A clear distinction between normal and abnormal emotional states is illustrated by the Yerkes-Dodson curve, which shows that up to a certain level of stress there is no impairment, but beyond a certain point, functioning deteriorates. The point at which this happens is determined by individual attributes such as genetics and personality predisposition, and by external factors including social support and the duration and severity of the stressors. Diagnostically, both ICD-10 and DSM-5 define these abnormal emotional reactions as adjustment disorders. With disturbance of mood include anxiety, depression, other emotions, and disturbance of conduct. Anxiety is an unpleasant affective state, and a simple definition is fear for no adequate reason. Sometimes the anxiety is accompanied by physical symptoms such as palpitations, sweating, difficulty breathing, and dizziness. Panic attack. If the physical symptoms occur suddenly and in combination, the result is overwhelming fear, and the term panic attack is used. Overwhelming panic may lead to inactivity or chaotic overactivity. Phobia. When the fear is restricted to one subject, situation, or idea, the term phobia is used, and is usually associated with physical symptoms of anxiety and with avoidance. Depressed mood. The term is bedeviled by the use of similar words to describe different mood states, like appropriate sadness associated with bereavement, the low mood that comes from frustration, or profound gloom that is part of severe depressive illness. Next is reactivity of mood. The term is used to describe the fluctuations in mood that occur in parallel with the changes in one's environment. Anxious foreboding is defined as a fear that something terrible will happen, although the person cannot identify what they are frightened of. It is present in several disorders such as generalized anxiety, depressive illness, and panic disorder. Demoralization. It is characterized by a feeling of isolation, despair, discouragement, and helplessness, common in those with serious psychiatric illness or physical illness like cancer. Differs from the low mood in depression since its source is seen to be external, and anhedonia and guilt are usually absent. Abnormal expression of emotion. These refers to emotional expressions that are very different from the average normal reactions. These can be excessive emotional response to an event or lack of proper emotional response to an event. This is termed dissociation of affect and is unconscious defense against the impact of overwhelming stress. Derealization and depersonalization are disorders of the experience of self and are associated with the feeling of being cut off or the feeling that object seems distant. Both of these conditions have an accompanying feeling of being unresponsive, and these are the most common examples of dissociation of affect. A neurobiological model involving an increase in frontoinsular or limbic inhibition has been suggested. Smiling depression. In this, the patient retains the communicatory smile but loses the emotional element. Their eyes remains unchanged and display a tension in the surrounding muscles. This may lead to an underestimation of the degree of depression and is particularly important when assessing suicide risk. Ballet indifference. It is rare nowadays. In this, people with severe disabilities are undisturbed by their suffering. Perplexity is bewildered or slightly puzzled state. Occurs in anxiety, mild clouding of consciousness, and emergent schiz. Those with these abnormal expression of emotion are generally aware of the abnormality. Coming on to morbid expressions of emotions. In this, the patient is unaware of the morbidity of emotional expression even though it is apparent to the observer. Inadequacy, incongruity or blunting of effect. This was called parathymia by Bleuler and is characteristic of schizophrenia. In this, there is abnormal emotional response to an event, partial or complete loss of all emotional life such that the patient is indifferent to their own or others' well-being. Emotional constriction or flattening. In this, although the emotion is expressed in the appropriate direction, the usual range of emotional response is limited. Stiffening of affect is seen in some patients with schiz. In this, their emotional response is at first congruent but does not alter as the situation changes. Lability of affect is the rapid and abrupt changes in emotion, largely unrelated to external stimuli. Is seen in depressive illness, mixed affective states, organic diseases such as damage to frontal lobe or cerebrovascular accidents. It is also seen in normal people who are excessively emotional or borderline personality type. Affective incontinence. In this, there is total loss of control of emotional response, and spontaneous outbursts of laughter or crying occurs, and is particularly common in cerebral atherosclerosis and in multiple sclerosis. In its most severe form, the terms forced laughing or forced weeping are used. Morbid disorders of emotion. These are pathological states that are triggered by stressful events or sometimes even without them, and do not spontaneously resolve with the removal of the stressor. These include adjustment disorders and depressive illnesses. Often the patient feels a tight band around his head and there may be a sense of oppression in the chest, and associated with anxiety, for which Schneider used the term vital hypochondriacal depression, now considered as somatization. Morbid depression also abolishes the normal reactive changes, leading to a sense of inner emptiness or deadness. And this loss of emotional resonance gives rise to complaints of depersonalization and derealization. This is also found in schiz secondary to insight, a consequence of failing memory or an integral part of the process itself. This also occurs frequently in association with morbid anxiety and can cause difficulties in diagnosing the depression. Morbid anxiety is also found in organic states such as acute and chronic brain disease, and when mild can produce anxiety mixed with depression and irritability. This was previously called organic neurasthenia. Morbid anxiety can also be secondary to terrifying visual hallucinations as well as present in psychotic states such as paranoid schiz. Irritability may be seen in depressive illnesses, schiz, mania or hypomania, and in mixed states. Short-lived periods lasting no longer than few minutes of depression, euphoria, anxiety, or unpleasant feelings may be symptomatic of temporal lobe foci. Extreme apathy may be a feature of severe depression, schiz, or damage to frontal lobe. This may result in self-neglect, inability to engage on day-to-day activities, and social disengagement. Morbid euphoria classically occurs in mania and hypomania, but can also be seen in organic states, and sometimes in schiz, especially the hebephrenic subtype, where the patient presents as silly and annoying. The addition of bipolar II disorder to DSM-4 in 1994 occurred in response to the increasing evidence that mild forms of the illness besides the mania depression, that is bipolar I, could also occur and remain undiagnosed, opening a debate concerning bipolar spectrum disorder and the upper and lower borders on this continuum, with some suggesting that up to 4 levels of bipolar disorder exist along this spectrum. Hypothalamus lesions may produce a clinical picture resembling mania with flight of ideas. Multiple sclerosis can have euphoria and is linked to the degree of organic brain damage. Amnestic syndrome has euphoria and a passive attitude. Frontal lobe damage with euphoria often represents as silliness, lack of foresight and indifference, and is known as moria or Witzelsucht. Ecstasy is an exalted state of feeling and is different from the morbid cheerful mood or elation, because unlike elation, it is not associated with overactivity or flight of ideas. Can occur in healthy population at times of profound religious experience or occasions of deep emotions such as following childbirth. May occur in schiz in those who misuse LSD, in epilepsy and mass hysteria associated with religious services.